All right, everybody, let's talk about diseases and conditions of the musculoskeletal system. So, Chapter 7. First thing, the musculoskeletal system, we have the supportive framework. So, we have the muscles and the bones. The bones are the structure, and the muscles aid in the movement of the bones. So, the musculoskeletal system, the reason we put the muscular system and the skeletal system together is because they're complementary to each other. Then we also have ligaments and tendons, cartilage and joints. And then the tissues, they give shape to the body, act as storage for minerals, serve as sites for blood cell formation, and all muscles are composed of muscle fibers. These are some of the major muscle groups: anterior, posterior, and the types of muscle. So we have striated and non-striated and cardiac. Cardiac muscle is actually striated as well, but it's striated differently than skeletal muscle. So you might remember that from anatomy and physiology or medical terminology. Muscles are also classified by being either voluntary or involuntary. And then we have the origin and insertion of muscles. So origin is the point of attachment of the muscle to a stationary bone, and then the insertion is attachment to the bone that is the moving, that is moved by the muscle. So different muscle types. Here we have skeletal muscle. It is striated or striped. And skeletal muscle are they're voluntary. So skeletal muscles we can control. So voluntary means we can control them. So those would be your the muscles that you move, like your biceps, your triceps, any of those large muscles. They also produce heat. And then the non-striated or smooth muscle does not have striations and is involuntary. So non-striated or smooth muscle lines organs and tubes throughout the body, and again is involuntary, so we don't have to control it. It's controlled by the nervous system and the endocrine system. And then we have the cardiac muscle, which is striated, but it's intercalated discs. So the striations are different than skeletal muscle. And cardiac muscle is involuntary. So, of course, we don't have to control it, thank goodness, or we'd have to constantly be trying to control the contractions of our heart. So skeletal muscle, striated, voluntary; smooth muscle, non-striated, involuntary; and cardiac muscle is striated and involuntary. All right, and this is showing you origin and insertion. So origin, this is the stationary bone. Insertion, this is the bone that will be moved by contraction of the muscle, and this would be the bicep. Normal skeletal system, we have 206 bones in our body. When we talk about the muscles, we have 600 to 700 muscles in the body. This is just showing you the different bones, which is probably a review of anatomy and physiology for you. So bones. Some bones encase and protect specific organs. So our brain is covered by the skull, so it has a lot of protection, as well as the thoracic cavity. So the chest, we have bones that protect vital organs like the heart and the lungs, and then also the superior portions of some of the abdominal organs. Bone cells are continuously forming new bone. So bone is always producing and forming and also being broken down at the same time. So it's a balance of forming bone and breaking down of bone. Composed mainly of connective tissue with a rich supply of blood vessels and nerves. So contrary to what a lot of people think, bones are actually living tissue. They do have vasculature and nerves. Types of bone: long and short, and then we have flat and sesamoid. This is just showing you some types of joints. Again, this is probably familiar from anatomy and physiology or medical terminology. So the ball and socket, cranial sutures. So it goes from freely movable to immovable, slightly movable like the intervertebral joints, and then freely movable again here with the elbow, which is a hinge joint. Pubic symphysis, which is slightly movable. This actually really only moves during childbirth. When a woman gives birth, this actually softens to allow for the pelvis to expand. And then we have the ellipsoidal joints, which are freely movable as well, which we see in the wrist. All right, joints. You have two or more bones coming together to form a joint. They are held firmly together, but they also allow movement. So they're classified by the type of material found between the bones, either fibrous, cartilaginous, or synovial. And they're also classified according to their degree of movement, like the previous slide. So immovable, slightly movable, and freely movable. And range of motion is the degree of movement, or ROM. Ligaments and tendons. So ligaments allow movement in some direction while restricting it in others. Remember, ligaments connect bone to bone. Tendons connect muscle to bone. So ligaments bone to bone, and tendons are muscle to bone. So tendons serve to attach muscles to the bones and other parts. They are non-elastic and are capable of withstanding a great amount of force from contracting muscles. So here we have some ligaments and tendons, and this would be the knee. We can see the patella here. And here's the femur, and then we have the rectus femoris tendon. So lots of different groups of tendons and ligaments here. All right, fascia and cartilage. Fascia is specialized flat band of tissue located just below the skin, and it covers and separates underlying tissue. And then we have cartilage, which is semi-smooth, very dense, supporting connective tissue. It's found at the end of long bones, and also cartilage is what primarily makes up the discs between the vertebrae. And then we have bursa, which make it possible for tissues to glide easily over each other without creating friction. So bursa are like little sacs, and there's a fluid that helps with lubricate and keep and prevent friction. Our first disease here, we have fibromyalgia. This is characterized by restless sleep, depression, fatigue, anxiety, bowel dysfunction, and then also pain. And there's a slide I'll show you in just a moment here. So diffuse aching, burning in the muscles, stiffness, disturbed sleep, poor concentration, irritability, and depression. And then the cause is unknown. So we would say the etiology is unknown of why people develop fibromyalgia. There's no specific laboratory or imaging studies that help with the diagnosis. So there's nothing that you can't get blood drawn or x-rays that are conclusive that say this is the diagnosis. So it's basically diagnosed by the clinical features. So treatment, patient education, stress reduction, physical activity, and medications. So these are the points where people generally have the burning or the pain. So these are the pressure points that are indicated for diagnosis of fibromyalgia. All right, lordosis. So we're going to talk about some spinal curvatures. So lordosis, kyphosis, and scoliosis. First is lordosis. This is also called sway back, so excessive inward curvature, and the person compensates for abdominal girth. So we see this in people with abdominal obesity and also in pregnant women because their uterus is large with the fetus and it pulls everything forward. So they have low back pain and it causes strain on the muscles and the ligaments. One cause is rapid skeletal growth that occurs without the necessary natural stretching of posterior soft tissues as well. But generally, we're going to see lordosis, which in people who are overweight or pregnant women. So when it's caused by pregnancy, delivery of the infant usually resolves the condition. When it's caused by obesity, then weight loss and exercises to strengthen the abdominal muscles are beneficial. Back braces can also be used. For severe lordosis, spinal fusion and displacement osteotomy are considered as well. And here you can see lordosis. So this here is a normal spine, the black lines here, and then this is the spine with lordosis. So it's very exaggerated here. So this would cause a lot of discomfort in the back. Kyphosis is also called hunchback. So patients may experience mild pain, fatigue, tenderness along the spine, and decreasing mobility. In children, it's believed to be developmental. Could be from tumors, tuberculosis, vertebral body of the vertebral bodies, and ankylosing spondylitis. Exercises to strengthen the muscles and ligaments are used, and back braces are also used. We also see kyphosis. Here you can see the spine here. This is normal spine, so it's actually exaggerated and kind of hunched. You also see this with osteoporosis, and that's from microfractures where they get this kind of curvature or hunchback. Scoliosis is a lateral curvature. So symptoms can be back pain, fatigue, sometimes shortness of breath with exertion. The cause is genetic in some cases. Others are deformities of the vertebrae, uneven leg lengths, muscle degeneration, or paralysis. Treatment depends on the extent and cause of the curvature. So with mild scoliosis, it may be treated with exercise to strengthen the weak muscles, and for severe cases, surgery. And in between there may be exercises along with back braces and before they get to surgery. All right, so this is the normal spine position in the red. and then this is the spine with scoliosis. So it's a lateral curvature. And this is a test that they do in children. I remember in elementary school having to stand, and the school nurse took a look at our backs as we bent forward to make sure everything was aligned. All right, osteoarthritis. So osteoarthritis, even though it has itis, which means inflammation of, it's more degenerative rather than inflammatory. So it's a result of normal wear and tear and occurs mainly in the large weight-bearing joints. So when we compare and contrast osteoarthritis to rheumatoid arthritis is an inflammatory condition, it's an autoimmune disorder, whereas osteoarthritis is from wear and tear and degeneration. So common symptoms are soreness, aching and stiffness, edema, dull pain, and deformity. Exact cause is unknown, but is generally associated with aging. And then treatment, physical and drug therapy, nutritional management, and supportive care. All right, so this is just showing the osteoarthritis. Here we have the normal joint, where we have the bone, the cartilage, and the joint capsule, and there's the synovial fluid, nice joint space here. Over here we have osteoarthritis. So now we have bone cyst, we have sclerotic bone, cartilage fragments, wearing down of the cartilage, and then over here with the advanced osteoarthritis, we have osteophytes, and we have calcified cartilage. So this might even, when the person in both of these, osteoarthritis and advanced osteoarthritis, movement of the joint, it might be a grinding sound because it's bone against bone, so the cartilage is gone. Lyme disease. No one is immune to Lyme disease, so we have typically a characteristic red itchy rash. Not all people see the rash, and I'll show you a picture in just a moment, but it's caused by the spirochete bacterium that is transmitted to humans by a bite from a small tick, the deer tick. So symptoms are similar to flu-like symptoms, so headache, fever, fatigue, joint pain, and general malaise. And then if the person does see this very characteristic bullseye rash, this lesion, it's a single lesion. We call it a target lesion. And we call it a bullseye as well because it looks like a bullseye. And then here's the tick, the culprit. So that's why it's really good when people go hiking and things like that, that they wear pants, boots, socks, and that you tuck your pants in your boots. Also, people that hike in areas where there's a lot of ticks should check themselves after hiking. Everybody does a tick check. They like nice little warm areas. So that's good to make sure that there's no ticks, embedded in the skin. All right, so treatment, removal of the tick, oral antibiotics, usually doxycycline, intravenous antibiotics, bed rest, and physical therapy. Prevention, avoid tick bites by wearing long clothing, inspect clothes and bodies for ticks, as I mentioned before. All right. Next, we have bursitis. So classic symptoms are tenderness, pain when moving the affected part, flexion and extension, limitation, and edema at the site of inflammation. So the cause of bursitis is usually some type of excessive friction or continual movement between the bursa and the surrounding tissues. Systemic diseases can also cause it, as well as infections and repeated trauma to the area. So this is just showing you the bursa. So they're like little sacs with fluid, and again, they help reduce friction. All right, so treatment of bursitis, avoidance of activities until the acute pain subsides, application of moist heat, immobilization, and non-steroidal anti-inflammatory medications as well, or NSAIDs, like Motrin. You can also use aspirin and acetaminophen, which is Tylenol. And then for some severe cases, local injection of a corticosteroid may be used as well. Actions that initiate or promote tissue inflammation should be avoided. So whatever kind of motion that increases inflammation, the patient would want to stop. Osteomyelitis. So this is inflammation, swelling, localized heat, redness, pain, and local tenderness over and around an affected bone are characteristic signs. And then symptoms would include chills, fever, sweating, and malaise. So this is an infection of the bone and the bone marrow. Often you'll see it will just say infection of the bone, but it's bone and bone marrow. So subperiosteal abscess may develop, causing eventual fracturing of small pieces of bone. Staphylococcus aureus is the bacterial organism responsible for about 90% of the infections. This is very serious. Somebody with osteomyelitis would need to be hospitalized, IV antibiotics, and they'd need to be monitored. immobilizing the area as well. So this shows you a picture here of osteomyelitis. You can see it affects the bone and the bone marrow. So treatment, like I said, long-term antibiotic treatment, increased intake of proteins, vitamins A, B, and C, bed rest, control of chronic conditions like diabetes, immobilization of the area, surgical drainage to remove any purulent material, and then hyperbaric oxygen treatments are also used. All right, gout causes severe or excruciating pain when attacks occur, generally affects the large toe in most people. It's an inherited abnormality of metabolism, so it results in a deficiency of enzymes that are needed to completely metabolize purines in foods for excretion. And so one of the things we would do with somebody with gout is put them on a low purine diet, which we'll talk about in a minute. So microscopic examination of aspirated synovial fluid from the joint demonstrates presence of urate crystals and proves the diagnosis. You can also do it with a uric acid level with the blood. So here is the joint affected by gout. This one as well. So you can see the uric acid crystals here. So that joint would be very inflamed and painful. So treatment, bed rest, reduce pressure on the affected joint, application of cold packs, NSAIDs, and corticosteroids, a low purine diet, and adequate fluid intake. So we don't want the person to get dehydrated. Excuse me. And then anti-hyperuricemic medications, so medications that are used to counteract the high uric acid levels, and then gradual rate reduction. So limiting alcohol intake, avoiding dehydration, and eating a proper diet are keys to not actually, you can't make it go away forever. You may just be able to reduce it. But it will reduce the amount of flare-ups. So the low purine diet would be things like red meat, alcohol, so wine, beer, any kind of alcohol, sardines, certain types of processed foods, cured foods, smoked foods, certain things like that. All right, Paget disease. This is affected areas of the bone produce new bone, and it produces the tissue faster than it can be broken down. And when the symptoms do occur, they usually occur in local or cause local bone pain. And then patients with no symptoms don't require treatment. So with symptoms, they give pain medications, anti-inflammatory drugs, cytotoxic agents, or injections of a hormone called calcitonin is used. And this just shows Paget's disease here. Marfan syndrome. So this is characterized by abnormally long extremities and digits. So there's other deformities such as subluxation of the lens of the eyes, the heart and vascular anomalies. The syndrome is an autosomal dominant genetic disorder affecting chromosome 15. So treatment involves controlling excessive height with hormones during or before puberty, and then preventing glaucoma, controlling blood pressure, and preventing aortic dissection. So this picture shows some of the features of Marfan syndrome. So the lens is affected, retinal detachment, cataracts, elongated head. Someone with Marfan's is actually pretty easy when you see them to know that they have Marfan syndrome, of course, if you know what you're looking for. We worry about aortic aneurysms, so that would, pretty much be immediate death if the aorta ruptures, vertebral deformities and long fingers and toes, and then they also may have floppy valves, so heart valves. Bone tumors. So we have a chondrogenic, which means they come from the cartilage, osteogenic, which means they come from the bone, and fibrogenic, which comes from fibrous tissue. So symptoms of bone tumors are pain, a limp because it hurts to bear weight on the area. It generally we see it in the legs. Soft tissue swelling, fever, and fatigue. The tumor weakens the bone and then makes it susceptible to this would be, you can call it pathogenic or pathologic fracture. That's where, because the tumor develops the weakening in the bone when the person bears weight, it snaps. So malignant tumors may be primary or secondary in origin, which means primary, they originate there, secondary, metastases from somewhere else. So here we can see an osteosarcoma. All right, definitely not normal looking. Treatment and prognosis of tumors, surgical excision and bone grafting. Tumor location may necessitate amputation as well, administration of chemotherapy and or radiation therapy, depending on the extent. And then the prognosis, of course, with any type of tumor or cancer depends on the tumor type, extent of the disease at presentation, and anatomic location as well. And, staging as well. Has it metastasized anywhere else? So muscle tumors. Skeletal muscle tumors often present as painless lump and often with erythema of the underlying skin. So redness would be present. Pain and tenderness may be present secondary to pressure. So maybe not the tumor itself is causing pain, but the pressure that it's causing on the areas around it. Smooth muscle tumors often cause pain and or bleeding from the organ affected. And then malignant muscle tumors grow by local extension and infiltration along tissue planes. Treatment and prognosis of muscle tumors. We have surgical resection of the tumors performed for all tumors. For sarcomas, surgery is often combined with radiation therapy. So they remove the tumor and then do radiation therapy. Chemotherapy is used as an adjunct to surgery in children with the rhabdomyosarcoma. Resection of pulmonary metastases may offer survival benefit, and prognosis worsens significantly with increasing tumor grade. So tumor size, lymph node involvement, and metastases. All right, osteoporosis. This is a wasting or deterioration of bone mass and density. So the bones become more porous rather than having density, which we want to support weight. So unless it occurs in the vertebrae or weight-bearing bones, osteoporosis usually doesn't produce symptoms. So, if it's in the arm, the person may not have symptoms, but let's say they fell on their arm, they may break the arm more easily than they would if they didn't have osteoporosis. It's caused by an imbalance between the breakdown of old bone tissue and the manufacture of new bone tissue. So this is showing you a metacarpal bone. So you can see here, there's definitely little holes here. This is lost the density. So this we have a ton of deterioration and holes. It's become very porous. All right, so when osteoporosis is detected, patients are further evaluated for hormone imbalances, kidney disease, and also diet inadequacies. So if the person's not getting enough calcium and vitamin D, then that's usually part of the problem. Also intestinal malabsorption and the use of certain medications. So certain medications may decrease, the formation of bone. They may also pull calcium from the bone. Treatment varies depending on the cause. So estrogen replacement therapy may be used for postmenopausal osteoporosis, and the outlook basically depends on several factors. How advanced is the osteoporosis? If you have a 80-year-old woman, women are typically going to be the sex that has osteoporosis. So more women have osteoporosis than men, so it's more common in women. And then the racial groups would be white or Caucasian women and also Asian women. Osteoporosis is less common in women who are Black and also women who are Hispanic. But it can still occur in Black and Hispanic women as well. It's just more common in white and Asian women. So if you have, let's say, an 85-year-old white woman with severe osteoporosis, starting calcium and vitamin D is not really going to be helpful. There are medications that are prescribed that you've probably seen on TV. One of them is Boniva. And so what these medications do is they just slow the process down of the breaking down of bone so that the body can hopefully catch up. And of course, a healthy diet, taking calcium and vitamin D will be helpful as well with treatment. All right, osteomalacia and rickets. So this is a word that's often mispronounced. Some people say osteomalacia, which is wrong. It's osteomalacia. It's a SH sound. So it's causes the bones to become increasingly soft, flexible, and deformed. So because the bones are soft, with any kind of weight bearing, they're going to be deformed. Early symptoms include fatigue, progressive stiffness, tender, painful bones, backaches, muscle twitches, and cramps. The metabolic bone disease results from deficiency or ineffective use of vitamin D. So vitamin D is very, very important, especially also for calcium absorption. And we know we can also get vitamin D instead of just taking a supplement. We get vitamin D synthesis through sunlight. So treatment involves vitamin D supplementation as well as dietary vitamin D, calcium, and also calcitonin. So here you can see a baby with rickets. So the bones are soft. So when they bear weight, now the legs bow out. Halus valgus, so this is a bunion. So symptoms, progressive enlargement of the first metatarsal phalangeal joint. So that would be the great toe. And local inflammation and pain, often result of a foot disorder known as Halus valgus. There's also a familial tendency. So treatment, wear shoes with bigger toe box using padding between the toes around the bunion, applying ice and analgesic medications. So part of the problem is we wear shoes that come to a point, or like triangle shaped shoes when our feet are squared. So it doesn't, it's not helpful. All right, and this is showing you the bunion. So a lot of time people think a bunion is a growth, and it's not a growth. It's actually, as you can see, it's just the bone, the MTP here. So we call it MTP for metatarsophalangeal joint. Now we have instead of the bone going straight, it's actually diverting. And so the meeting of these two bones at this angle is what causes the bunion. Halus rigidus, this causes pain and loss of motion in the joint. The MTP joint becomes painful, stiff, and swollen. So degeneration of the MTP joint can occur as a result of injury and also underlying arthritis. So we do x-rays to confirm the degenerative process. And then conservative treatment includes pain medications and anti-inflammatory drugs. So here we can see the Halux rigidus. So there's no space here, whereas these are all normal. So here we have the bone on bone. All right, hammer toe. So this is a deformity, can be painful and often causes abrasion and inflammation where the flexed toe rubs against footwear. So congenital tendencies and shoes that are too short or have high heels that people wear contribute to it. Switching to shoes that fit properly and allow enough space for the second toe can reverse the process. So here we can see hammer toe. You can see the toe here. All right, so this would be the one affected, and you can see how it's instead of lying flatter here, it's actually at an angle. And then this is one of the ways that they could fix it. What they do is they go in and they put a pin through and align everything back up. Okay, and this pin sticks out, so this would be all bandaged up. This would be a sterile surgical procedure, of course. And then after everything heals, they pull the pin out, which does not feel really good and should be numbed up with lidocaine or xylocaine before they remove that. All right, fracture types. What you're going to want to do is look through your book at the different types of fractures, be able to identify them. So it's just the list here, and you have all the pictures in your book. So I know you're able to actually look at those. So be able to identify those for your exam. So what is a fracture? A fracture is any break or disruption in the bone. So it's usually accompanied by pain, edema, tenderness, discoloration, and inability to move the affected part. The inability to move may not always happen. Some people actually may walk around on a fractured area. It'd be very painful, but it doesn't always prevent movement. So any force, external or internal, that disrupts the continuity of the bone causes a fracture. So the bone doesn't have to be broken all the way through, excuse me, in order to be a fracture. It could be a chip of bone, could be the green stick, which you've seen, which does not go all the way, which you see more commonly in children. And then we have, simple fractures, which can be reduced and immobilized, and then compound, which means it's open through the skin. Those have to be cleaned, reduced, immobilized. That would be done in surgery, and then the patient would be on antibiotics to prevent infection. All right, amputation. So most limb amputations involve the legs and occur because of peripheral vascular disease from atherosclerosis. So plaque buildup in the arteries. So the extent of the amputation can range from removal of a portion of a digit to complete disarticulation at the hip or shoulder. So rehabilitation is important and is attempted as soon as possible. And then some patients have phantom limb pain. You had that in your first chapter, and that's where they have pain but the limb's not there anymore. And that's because the nerve, when they amputate, the nerve where they cut, it still gives them the feeling that the limb is still there. So they may have pain there. So when we see amputations from peripheral vascular disease with the atherosclerosis, we're also seeing that related with diabetes. So type 1 and type 2 diabetes, because diabetes is a vascular disease. Strains and sprains. So students often ask me, what's the difference between a strain and a sprain? So a sprain involves a joint. So a sprain, you can sprain your ankle, you can sprain your wrist, you can sprain your knee, you can sprain your shoulder. So that involves the ligaments, and then a strain usually is tendon or muscle. So you can strain your bicep, you can strain a hamstring. You can't sprain a muscle because it's not a joint. Okay, so it can be from acute injury, a result of chronic overuse. Symptoms usually include pain, weakness, numbness, and possibly edema around the site. So treatment of a strain or a sprain, we use what we call RICE, which is rest, ice, compression, and elevation. So you want to rest the area, ice it, compress it, and then elevate it. And then there's also MICE with an M, which is movement, ice, compression, and elevation. So sometimes rather than just keeping it immobilized, they may want some movement. And a lot of time people will do that in therapy with like a big ice bucket, and they'll rotate, let's say their ankle, they'll move their foot around in the ice water. All right, so this is just showing here an ankle sprain. So here we have the anterior talofibular ligament and then the calcaneofibular ligament. So there's a tear here, and that would indicate the sprain. So it's a joint, so it's a sprain. All right, dislocations. A dislocated joint appears misshapen, and that's because the bones are not in the proper place. They are very painful. They can become very swollen, bruised, or ecchymotic, and immovable. So if someone has a dislocation, they're not able to actually use that area or move it. So it requires immediate emergency medical care. So when a joint is out of place, there could be compression on blood vessels or nerves. So it needs to be put back in place as soon as possible. The cause of the dislocation is usually a severe injury that exerts force great enough to tear the joint ligaments and pull the bones out of place. So you see this in sports a lot, football, soccer, those types of things where there's dislocations. Physicians should be seen immediately for proper repositioning of the joint. So this is showing you here. So the normal position of the humerus would be here. All right, it would be here. We have the clavicle, we have the scapula, and then this is showing a dislocation. So this person would not be able to move their arm. They wouldn't be able to lift it or move it or rotate it, and they would be in a lot of pain. So what they would need to do is then reduce and put it back into place. All right, adhesive capsulitis or frozen shoulder. This presents as a shoulder that's become stiff and painful, making normal movement impossible. So the pain can be localized in the shoulder or it can spread out. It could go into the back or the chest. It's caused by inflammation of the capsule of the joint with secondary scarring. So there's initially inflammation, and when it resolves, it scars. And so when you scar that capsule of the shoulder, now it's frozen. And we also call scarring adhesion. So that's where you get the term adhesive capsulitis. So a stiff shoulder must be kept in motion. So they're going to use pain medications, anti-inflammatory agents, injections with steroids, and then they're going to need physical therapy to really kind of break up some of those adhesions and scarring and get some shoulder movement back. severed tendon. So a severed tendon produces immediate severe pain. It's not something that somebody wouldn't know they had it. They'd have inflammation and immobility of the affected part. So remember, tendons attach muscle to bone. So the cause of a severed tendon is an injury or laceration, and the surgeon may suture the two ends of the tendon together immediately or may wait for the injury to heal. So this would be, some surgical intervention. So here we can see here a severed tendon. So this should be attached here. This person would not be able to move this finger because now the muscle that is supposed to attach here via the tendon is not working. It's not attached anymore. That would be surgically repaired. Shin splints. So inflammation, edema, pain, and tenderness along the inner aspect of the tibia are common symptoms. So between the tibia and the fibula is some connective tissue. And so shin splints can be from overuse and overpronation. Those are the most common factors. Runners, people that do a lot of jumping, they may also be more predisposed to develop shin splints. The key to successful treatment is rest. Application of ice or heat are essential, and some people will take anti-inflammatory medications to relieve some of the discomfort and also other types of pain medications. But for runners, they're going to have to take maybe several weeks off to recuperate and then get back to their running or whatever exercise. Excessive foot pronation. So you can see here, this area should actually be over here. It should be straight up, and it's actually pronating inward. So this is not good for the joint area here. And just keep in mind, anytime you have a problem with one area in the joints, imagine this offsets not only the ankles, but if you work your way up, the knees, the hip, and then of course the back. The spine is going to be weird and out of alignment. Plantar fasciitis. So problem begins as a dull intermittent pain on the bottom of the foot, which can progress to a very sharp persistent pain. I've actually experienced plantar fasciitis myself. I used to run a lot, and I developed plantar fasciitis, and it felt like a hot poker was in the bottom of my foot. It's extremely painful, and depending upon the extent of it, some people can just wear certain like orthotics or shoe inserts. In my case, I actually had to get an injection into my foot and wear a cast for 4 weeks, which was not fun. Walking around with a short leg cast, but that's what it took to let it heal. So usually occurs when part of the inflexible fascia is repeatedly placed under tension. So with people with flat or pronated feet, like we saw in the previous picture, high arched rigid feet, toe running or hill running, and then running on soft terrain like things like sand. So I was a prime candidate. I used to run all over the place. All right, initial treatment, resting and applying ice to the sore area, taking anti-inflammatory analgesic medications, and using heel pads. After the inflammation has subsided, physical therapy to strengthen the small muscles of the foot can also begin. In some very severe cases, let me see if I have this picture. So this is showing you a heel spur, and then here's the plantar fascia. In some cases, people will have actually have surgery and cut the fascia. If they get chronic plantar fasciitis and they just don't want to deal with it anymore. So they actually go in and do a release. They cut the area, which to me does not sound like a fun surgery. Ganglion most commonly develops in the back of the wrist as a single smooth lump, and it's just under the surface of the skin. So the reason it's mentioned here is because they're usually over a joint. They may be soft to touch or firm. They're usually either painless or only somewhat bothersome. If they get really large, they may limit the range of motion in the wrist. The underlying cause is unknown. We don't know why. Some physicians may apply pressure to try to break it up, and others might do a needle aspiration to remove the fluid. So here's a ganglion. So, if this got really large, it might actually limit the range of motion in the wrist. For some people, if they're small and they don't bother them, they don't have to do anything. You really only have to do something if it's problematic. Torn meniscus. So medial meniscus is more often injured or torn. A person with a torn meniscus usually has acute pain, so a rapid onset of pain when putting full weight on the affected leg. And then full flexion of the affected knee may be difficult, and pain increases with full extension. Most torn menisci are related to sports injuries, as well as, most knee injuries are related to sports. And the injured knee should be immobilized immediately and elevated and ice applied. So this is showing you here the normal knee. And the meniscus, you want to think, here's lateral meniscus, here's the medial meniscus. They're cushions. So they're basically cushions in the joint. And so here we have a tear. So that would be very painful. All right, rotator cuff tears. Tears in any of the rotator cuff tendons limit shoulder function. So tears in the tendon of the rotator cuff muscle can produce an immediate snapping sound and acute pain. It really depends on the extent. Some people may have a small tear. They may not be limited too much. Others may have a larger tear, which now they can't even abduct their arm, so they can't raise their arm or rotate without being in excruciating pain, or they may not be able to do it at all because of the tear. And they can result from acute trauma or from degenerative changes with age. There's acute pain, which can be managed with pain medications, and then anti-inflammatory medications also, and then, of course, acetaminophen, which is Tylenol. All right, so this is just showing the structures of the shoulder. So we have the coracoid process here, humeral head, and then the glenoid process. So this is where the humerus fits right in here. All right, so that is it for the diseases and conditions of the musculoskeletal system, Chapter 7.